everyone. I will be going through the clinical assessment midterm oral practical exam in this video. Basically a big review. I will try to explain step by step what we are expecting to see from you during the exam and how to basically get a great mark during the exam for this particular OP. I'm gonna try to give you some pointers, try to give you some warnings on things, not to do's, common mistakes, as much as I can remember, as much as my experience allows me. As you know, I've been doing this for a while now, teaching clinical assessment and doing the exams, particularly for a long time. So when I say like common mistakes, I actually do mean common mistakes. They happen quite a bit. So I'll try my best to give you the fair warning, so hopefully you won't be making those mistakes, plus some of the things that I've seen that caught my attention in a positive way. So I would like to also point that out. This isn't exactly, I wouldn't want you to take this into a copy-paste mentality and do exactly as I say, because I will try to make it subjective to a degree, because this is assessment and every assessment is different from each other. Everybody's different from each other, so try to make it on your own and try your assessment to make your own, staying within the confinements of professionalism, safety, and effective assessment, because that will also translate into your treatment and your reassessment anyway. I'll try to give you other examples to see what we have. So you can see from the top here on the tabs, I have multiple things that I will go through. Particularly, we're going to be in this video going through midterm OP marking sheet. I will show you the cases. I have no problem showing you the cases. This will be literally the cases you're going to be seeing on your OPs. I don't have any problem with showing, because we're looking for skills, not memorization. And then I already prepared a direction PDF file. It's already in your SharePoint. It's already available to you for you to read. So I'm hoping that with that and this video that you will be perfectly prepared, that you walk into the classroom and you know exactly what's going to go down and how you're going to do, and you're fully prepared. Okay, so let's start. So it is out of 50 marks, okay, 50 points, and your examiners will be right here, myself, Paula, and most likely Keith. For the midterm, we're only focusing on 3 joints. Okay, you're gonna be seeing, because by this time you're gonna be going through only shoulder, elbow, and wrist anyway. So your midterm examination is also basically consisting of these 3. So from the get-go, from the very beginning, you should look at this and basically understand that, okay, I'm gonna have one joint and one joint only for my examination, not all 3, only one. Okay, and you will also be getting one problem only. So it is very simple, very simplified, straightforward, one joint, one problem only. Okay, so when we look at the cases right here, we can immediately look at the cases. So you can see that there are 9 cases that I prepared. Okay, I will cut these into small pieces by themselves on these rectangles, and then they're gonna be face down, turned. So you will walk in to one of the 3 examiners into the classroom, and then go to your examiner. You will have the schedule by then anyway, so you know who examiner you're supposed to be going to, and then that examiner will allow you to choose one of the cases. They're gonna be upside down, so you won't really see them. In this way, basically, your classmate, your teammate will not get the same case. We will also aim that if you get a shoulder case or your partner gets a shoulder case, you will be getting an elbow or wrist case. Okay, so you're not gonna get both shoulder cases. We're aiming for difference in the OPs, so there's no same thing happening over and over again. Create a bit of a variety. So let's say for the first one, for example, right here, so these are all in the direction PowerPoint as well, not PowerPoint, sorry, on the PDF as well, but here we go. So right anterior shoulder pain on the anterior shoulder. So you have a shoulder case, immediately it's very obvious, okay? The pain on the right anterior shoulder basically tells you where you're supposed to be charting this, which is exactly what my point is. Right here, you need to be charting right anterior shoulder pain, okay? If you remember from the class, pain is signified as X. So we are looking to see a circle on the right anterior shoulder with a 1 degree, which would be primary area of concern, and X in the center of the circle to signifying pain, because you're gonna see there's dull ache and pain depends on the case. So when it comes to dull ache, we are looking for a circle within a circle. That signifies that it's achy versus painful. So that's number one thing you're gonna be immediately doing whenever you want to, but just for point purposes. So you will turn the case and find out what your case is. We're gonna give you a second to collect your thoughts, okay? And then we're gonna start the time. You will have 10 minutes, okay? So to perform basically an ISC, functional assessment, okay? You're gonna see right here. Initial scan exam, functional assessment, and one of the range of motion testing, whether it's active, passive, or resistance. You're gonna see the case here. It will say functional test, please do. And you need to do only passive range of motion when it comes down to this case. When it comes to this case, we are looking for you to do resisted range of motion. It is a shoulder case on a lateral aspect. So from this example, and jumping from this first one to the second one, lateral shoulder, right lateral shoulder, which means that we need to basically come here, put a circle, okay? The common mistake is mixing it up with this, guys, these two. So know your right and left, okay? Right shoulder right here, and then circle with a 1 degree again to determine primary area of concern, primary complaint, and then circle again inside to determine whether it's pain or ache, dull ache. So that will be signified. And you need to be basically starting with the ISC, initial scan exam, okay, which will require you to go down here and do your alignments for the person. Now, we already talked about this in class, so this is not the time that I will describe initial scan exam to you. So please refer to your PowerPoints and note packages and email me or ask me in class if you have any questions based on that. I will also, if it's not at this time, but I will in the future prepare an ISC assessment, basically initial scan exam and palpation video as well to explain with examples. That's why these are here for. Hopefully after this video sometime soon, but this video's purpose is the midterm itself, so not that. But so you're expected to do an initial scan exam to start, okay? You have to start with initial scan exam. Do not jump into functional assessment. So functional assessment following, okay, after the initial scan exam, you need to do a functional assessment. As you know already, we only require you to do 2 functional assessments. So if I told you most painful action is flexion, okay, it already tells you which one is the most painful, which means from protocol you need to be doing this last. So if it's right anterior shoulder problem, so right shoulder problem, then you need to be starting with left, because that's the protocol, unaffected side first. And also your protocol dictates that you need to do the most painful one, most painful motion last. So case tells you everything, and I want you to make sure that after your functional assessment, pass the AROM, skip AROM, and go to passive range of motion, and you do not need to do resistant range of motion in your 10 minutes. So it should be pretty straightforward, pretty easily, okay? So that's your case. Your functional assessment needs to be charted right here, okay? You'll have plenty of time to do that. You're gonna be charting your functional assessments right here, grading and pain here, okay, if there is any pain or not. So we're going to talk about that. And then you need to move on. Your ISC, you're asking for orthotics and etc. We're going to come there. And then if it's a passive range of motion, we are only looking for the I symbol, or if it's an active range of motion, S symbol, or if it's resistant range of motion, you don't even need to do anything here. We just need to come here and fill out the information that is necessary for our resistant range of motion right here. Okay, so look at the case again. You're gonna see resistant range of motion, passive range of motion, and that's it. You can actually see that I'm not even going to be going through an active range of motion during our midterm. So all you have to focus on is passive range of motion and resistant range of motion of shoulder, elbow, and wrist. I believe active range of motion is pretty easy, straightforward. That's why I'm not asking on the midterm. I would like you to be hands-on with your patient. So let's start with the exam. Okay, so you know your case now. You know right or left. This is my exam paper. You're not gonna have access to this. I'm just marking you as we go. So we have this portion is extremely important. You need to get consent from the patient, from your client. You need to explain the procedure by simply stating that I will be starting with a soft eye exam. It's called initial scan exam, and I will be doing a hands-on assessment in the meantime while I'm doing these tests, while I'm doing these assessments. I will be doing hands-on assessment. If that's okay with you, I'll check your alignments, I'll check your arches and certain bony landmarks. So that's what the hands-on assessment is for. And also I will be palpating and checking the tone, temperature, tenderness, and texture basically of your shoulder, elbow, wrist, whatever the case is, of that side. Okay, and again, palpation needs to be on the unaffected side first and then affected side, so we're going to be looking at that. Okay, so just so you know, you give this explanation to the client. Under a minute it should be done, and then the person needs to be saying, yes, I understand, you have my consent, yes, I understand, whatever. So that's what we call it, informed consent. Please, like, common mistakes on this point is that, okay, stent, okay, thorax, like there's no explanation, no consent, know what you're gonna be doing. Your disadvantage here is an honest one, is the person you are doing the assessment knows what you're doing, so you get comfortable with it. But in real life, the person will not know what you're going to be doing most likely, so you actually need to examine and explain the patient what you're about to do. You shouldn't just start touching them and be like, I'm just doing an assessment, what's the problem? You need to explain. That's the point of informed consent. Okay, so it's out of 2. But if it gets too uncomfortable, and professionalism marks also will be cut down. So it depends on how you're handling yourself and handling your assessment. It has to be done gracefully. After you get your consent, you need to be asking the patient whether they're wearing orthotics or not, okay? Because you need to be asking them to remove their shoes, okay? So this is a point that gets forgotten sometimes, but it is fine. It is an honest mistake. So please try to practice this so you don't forget. And as you point out right here, I wanted to make sure that I'm actually clear with you guys. This needs to be asked before you start your soft eye exam. I had many people did the soft eye exam, okay, while they're wearing the shoes, and they didn't even ask orthotics, and they just begin the procedure, soft eye exam, and then once they started to check for the landmarks, they go for the arches, and then they realize that they forgot to ask to remove the shoes. So this is why I say, okay, you did a soft eye exam, you marked and everything, now you realize that you made a mistake. Now this is where you have to make a call. Should I continue by asking to remove their shoes at this point, because you have to by checking their arches and ankles and knees, hips, but do I go back and do another soft eye exam as quickly as possible? Well, if you have the time, go for it, because we definitely want to see a complete proper exam. But if it's a judgment call, if you took too long, okay, you're gonna lose some marks. Obviously, we're not gonna be completely butchering the exam and giving you zeros left and right, okay? But you're gonna lose some marks, which is okay, which happens. It's just the anxiety of the exam. But I want you to make a judgment call there and either continue or go back and redo it. I'm not gonna tell you what to do on that, because it depends on how much time you spend in the first place with the 4 views, with the anterior, posterior, and both laterals. And because you, after that, you have to judge your time, because you have to spend a decent amount of time on palpation, and you have to a decent amount of time for the assessment, functional assessment, and passive or resistant range of motion. So assuming everything is going well, you've done your proper comments for the wearing orthotics, whether they're wearing orthotics or not, and then you ask them to remove their shoes, and you did your body procedure, basically 4 views. Everything is done on that front. So now you're checking for the landmarks. Okay, so you can see basically I put already what I'm looking for, what you need to be looking for. So I'll try to go on one by one and basic information for this. So in class we talked about the arches. So just to remind you, basically 1 or 2 basically fingers height we are looking for. You need to put it in the, you need to put your fingers, 1 or 2 fingers, beat underneath the arches, right around the center of the arches, to find out how high or low their arches are. And then after that, you're checking for the malleoli, basically the ankles. Okay, you need to compare right versus left, lateral malleoli on bilaterally. Basically, you're comparing it. At this point, if you don't know exactly what you're looking for, it's okay, just for the muscle memory and practice. Basically, keep doing it, keep trying to understand the difference between right and left. Just see if you can find a difference. It's not a big deal, because later on we're also going for the medial malleoli as well, trying to see if basically the relationship between tibia and fibula, and then we check for the femur as well. There is something called leg length discrepancy. But right now don't concern yourself with it. After that, we're also checking for the knees, and when I say knees, I'm mostly meaning patella, because you should be able to look from the soft eye exam whether it is genu valgum, genu varus, there's whatever. If there's hyperextension on one side versus other, like hypermobility per se, maybe, I'm not sure if it's locked knee on the right one or left one. Those should be identified at the soft eye exam. But if they're wearing pants, if it's baggy or anything like that, this is a good idea to check the knees again. And basically you're checking the patella's level. If one patella is lower or higher than other, it has its name. It's like patella baja, patella alta, and stuff like that. So, but again, there are certain pathologies that right now you shouldn't concern yourself with. So this is more of an observant report. When it comes to hips, we're looking for the height of the hips particularly. When you're checking from the anterior or posterior aspect, we're looking for the high point of the iliac crest on both sides, trying to see if one hip is higher than other. From the lateral aspect, I'm going to also ask you to do, if you can, just attempt at least. From the lateral aspect, you're looking at ASIS, which is anterior superior iliac spine, and PSAS, which is posterior superior iliac spine, that you're trying to know the difference between them, the alignments basically. So technically, anterior superior iliac spine should be a little bit lower, about an inch or two, about a finger or two lower compared to the posterior iliac spine, posterior superior iliac spine. But that's what you're basically trying to identify. But at this point, if you cannot, it's okay. It's too early in your program to be able to identify that. So just at least check for the iliac crests alignments as I show in class. After that, you're skipping the entire trunk. We're not looking for anything there. I want you to look at the shoulder alignments. That should be basically comparing your soft eye analysis, soft eye exam, and simply if there is any baggy clothing, you push it down, trying to check the shoulder alignments, if there's interior, like internal rotated, external rotated, etc., that kind of stuff. After that, technically you can look at the head and shoulder relation, and then once you're on the lateral aspect, I want you to check for the lumbar curvature, thoracic curvature, and cervical curvature as much as possible, as much as you can see. Especially lumbar curvature and thoracic curvature might not always be obvious from the soft eye exam. That's why you need to actually hands-on assess that. So we're checking for the curvatures, if whether they are hyper or hypo or normal, whatever. Now traditionally students go through these actions, okay? This is a not to do. So they go through these actions and they mark nothing afterwards. So they don't necessarily chart anything else. So just to go through the motions for the sake of exam, and then they chart nothing, which is a big problem because you can still find out a lot of information from their hand-on assessment. So yes, you need to write down some soft eye exam stuff, absolutely. But after that, go back to your paperwork and see if you can add more information based on your hands-on assessment. Okay? So once you're done that, now we are going to the palpation section of it. Now this is kind of straightforward because if you have a shoulder case, let's say in this case you're looking at an anterior shoulder palpation, anterior shoulder case, with the flexion being most painful. Okay, so in this case we are going through this by simply palpating. If it's a right problem, then you need to start with a left palpation, and I show this in class. We are looking for a relatively MSAK level of palpation, so please refer to your notes in the class the way I'm doing and the way I showed you and the way I said don't do it, basically. So it's important to basically do a thorough palpation on the primary area of concern. So unaffected side first, and then affected side. That's very, very accurate. Okay. After that, you need to basically chart all this information properly. Okay. Alignments as detailed as possible. Accuracy for the palpation as detailed as possible. So we're looking to see if you can give us a detailed palpation when it comes to texture, if it's clothing, if it's skin. Okay, if it's skin, if it's is it hairy, is it dry, it is sweaty, it is whatever. Okay, there are many examples in our lectures, right? So use one of those. For temperature purposes, again, is it within normal limit, or is it warm, is it cold, is it something else? Like, just tell me what you're feeling and then write that down. You don't have to tell me, just it's a figure of speech, and you just need to write it down on your palpation section, which is again right here. Okay, right here, palpation section, we want you to definitely look into that. So write down all the 40s of information, if you know, whatever you can come up with. And don't forget the tenderness, which means that during your palpation you need to ask the client whether it hurts or not. We might, as the examiner, tell you that yes, there is a particular place that is hurting, right here, right there, whatever. We might give you the location. So again, it needs to be as specific as possible. So if you're writing for tone, which you need to, one of the T's for all the 40s of palpation, I would like you to give me a muscle name, at least one muscle, at least, like, hey, it's tone on the shoulder, anterior shoulder, there's anterior fibers of the deltoid is tight, or lateral fibers of the deltoid is tight, or posterior fibers of the deltoid is very tight, or upper trapezius is very tight, whatever. Like for the shoulder, for the elbow, for example, extensor digitorum tends to be very tight, or triceps tends to be very tight, because you need to be palpating, proximal and distal to a degree of the joint, because joint palpation, you're basically looking for tone of the muscle. So please regard those as much as possible. There are many examples of that in your SharePoint, so you should be able to find that out. And then overall professionalism and communication throughout the procedure. It's an easy to mark as long as you're being professional and you talk. You have to explain your procedure to the client, get proper consent. So it goes hand to hand with the explaining procedure, get consent. That's before you start doing anything. And this is throughout the procedure. Continue to talk, because this happens quite a bit. People actually explain what they're gonna do, and then they don't talk throughout the exam at all, which gets really awkward. It's a very awkward silence for about 5-6 minutes. And I'm not gonna basically, or any examiner is not going to basically push you in that direction or give you verbal cues to, like, hey, call, talk, communicate, whatever. We're just gonna awkwardly start marking. Okay, so the next portion is basically, as I explained earlier, we are going to see you do functional tests, 2 of them, okay, and then active, passive, or resistant range of motion, any of them, okay. And as I pointed out earlier on, that you will not be doing any active range of motion with the proper point, like current cases that I will be giving you to do on your midterm. So we are looking at passive and resistant range of motion, and that's basically the exam. So let's go through the functional test, what we are looking for. Now I will write down which joint you're going to be doing your tests, and the most painful one right here. So when you choose your case, This is what we are looking for: painful action, flexion, functional tests, 2 of them, and then passive range of motion for this one. For lateral elbow, for example, most painful action is supination, and there's functional tests, and there's just range of motion. So as you know, we go through functional assessments, functional tests in class, and I try to keep them as little as possible, as few as possible. So for shoulder, we have 4 functional assessments. There's the flexion assessment, extension assessment that complements to each other, and you have the abduction and adduction test, which they also complement to each other. So when you get an abduction case, I want you to do definitely, like for example in this one, there's a flexion case. So I definitely want you to do flexion to 90 degrees test and an extension test, and then you're good to go. So when it comes down to elbow, for example, if it's an extension test, then we're looking for the elbow flexion test, and then with the weighted, so that's what the whole point is, and then the wall push, which is for the extension test. So it's up to you, okay? And for example, for wrist, again, we're looking for weighted wrist flexion and weighted wrist extension, just to complement each other. And for the ulnar deviation, same idea. There's basically a radial deviation, and then because we don't really have an ulnar deviation case, because I will mention that in class, then we're basically looking for a flexion or an extension that it will basically, anyone will basically do, okay? So keep that in mind, please. So, all right. Explain the procedure to the client, get consent, just like the ISC. So basically your wording is extremely important here, as clear as possible, and then the body needs to give you a consent, a clear yes, so you have a consent. And then after that, you need to choose the most effective tests for these, which I've already mentioned, executing them, grading them, and recording them tests correctly. So recording those tests correctly. So at this point, we're gonna go back up here, functional tests, okay? Right in this section, you need to be writing right here those tests: weighted flexion, weighted extension, whatever the joint is. So weighted elbow flexion, wall push, or weighted wrist flexion, weighted wrist extension, I don't know, whatever, shoulder, weighted shoulder flexion, weighted shoulder extension, whatever needs to be. And then the grading is very simple, as we talked in class many times: functional, functional fair, functionally poor, or non-functional. Any of those will do, okay? Again, please check for the examples that are given in class, which I'll have another video for that. I haven't recorded it yet, but I'm pretty sure hopefully by this time you're reading this or watching this, there is an additional how to do ISC tests and how to mark them, how to grade them, how to assess them, how to chart them, examples video. But you know, regardless, please refer to your examination for the examples on your SharePoint. Then your grading, and then you have to check for the pain. So please make sure that you're actually checking for the pain. That's what I put down, functionality and pain right here. Again, professionalism and communication throughout the procedure. Really, it's an easy 3 mark as long as you're actually talking and being, you know, friendly and clear and precise with your body. After that, we are going through the passive and resistant range of motion, or again, passive or resistant range of motion, because you're gonna have to do only one of them. So let's say if you're doing passive range of motion, because this is something that people get quite a bit wrong, I'll have to be very precise. So please listen very, very carefully. Like pause the video if you need to take a break, because these are where people lose a lot of marks. So you're explaining the procedure to the client and get consent. Same idea, same thing. Hi, like whatever person's name is. So we're going to continue our assessment with a passive range of motion. At this point, I will be doing all the motions, so please try to relax as much as possible. I'll be doing hands-on assessment, so your relaxation is paramount here. If it hurts at any point, please let me know. I'll also check with you if it hurts or whatnot at any point. So, you know, just let me know if I need to stop the assessment. I will stop, no problem. And please lie down supine, or please have a seat, please stand up, whatever the procedure is. Please like make sure be precise there, explain the client, because that's where you're getting marked at. Okay, and then start with the unaffected side, bilateral comparison, just like everything else. Now limb handling, people tend to lose a lot of mark. I want you to be taking the client's limb as much as possible, and they need to relax as much as possible. So you cannot just waggle the joint and move it around and swing it, and just, if it's hurtful, then it will be hurting. If they're actually in pain in real life, it will be hurting. So that's gonna be a problem. So you need to be very conscious about the problem, and handling the tissue is extremely important, because that's what we do. We are the muscle people, as I joke in class. Then the logical progression is basically, when you assess one side versus other, I would like you to be precise, and I would like you to stay consistent. So let's say for the shoulder, if you start with the flexion and you proceed with extension and then abduction and adduction and external and internal rotation, I would like you to do that on right and left, or left or right. So unaffected side first and then unaffected side. So stay consistent. And logical progression should be technically with the force couples, whether you can, like wherever, if it's applicable. So if you do flexion, I would like you to follow up, with an extension. If you do external rotation, follow up with an internal rotation. When it comes to elbow, if you do supination, follow up with a pronation. Don't be all over the place. Okay, so that's where you get your marks, or you lose your marks, based on how logical and how consistent your progression is. So most painful is last. Okay, and you have to do, of course, all the motions that we always tell in the class. Like, how many motions does the shoulder AROM has? 6. Okay, that's what we're looking for, 6. Okay, and check pain during testing. So as I said in class before, I don't want you to check it 6 times, but 2 times would be great if you check it. Prior to the examination, you tell them, like, if it hurts at any point, let me know. And then during the exam, if you ask for once or twice, say, is it painful? Or after the exam, if you're done, was it any pain in between any of those? Then you're good to go. You'll get the mark. And record passive range of motion correctly, which you know where it is by now. It's the big guy, as I call it. Okay, sorry, my bad. Is it right here? Okay, right here, basically for passive range of motion, it has to be the single lines that we talk about in class. Please refer to the lecture notes and the video, hopefully, for that, and then basically just go through the actions there. We're putting the joint right here. Okay, and you can circle the affected side and circle the most painful for your reference, and it's always a good one, so we know also which is the most affected side, etc. So definitely I would highly suggest, like, circle the affected side and circle the most painful. So in this case would be, for example, shoulder, left, abduction right here. So shoulder, left, and abduction. So this way you can actually just circle all that, and that gives me the idea that, okay, it's a shoulder and it's the left side affected, and abduction is the most painful. Okay, when it comes to resistant range of motion, I'll talk about it when we're there. So that's it, basically recording, and you got your 12 marks easily. Okay, so that's very, very important. All right. For the limb handling, okay, that's also where you lose marks for and feel. So that's one of the big things that I mentioned in lecture. So keep that in mind when you're talking about and feel. This is where you end up losing marks 1 or sometimes 1.5, because you need to go to the end range and then push a little bit more, which is called passive overpressure, and then you're good to go. And then that's how you check for the and feel. So please refer to the and feel lecture and notes for the precisely how to get full marks and what to do and how to chart it if it comes down to it. Now, during the exam, okay, this is the same with passive range of motion, same with resistant range of motion, same with functional assessment. We might tell you that something is painful. Now listen very carefully. We might actually say, hey, right shoulder abduction while you're doing it. We might say, oh, you know what, that's very painful. They can't complete the action fully. They can only do it 75%. So when that happens, especially during passive range of motion, that would require you to go to abnormal and feel, because we said it's painful, that they couldn't do it. Then you need to mark that as joint shoulder, and let's say we said left abduction right here, you need to write it down. And the and feel concept needs to be empty, because you couldn't feel it. Okay, empty because you couldn't feel it. you didn't know how it felt, so your input is empty. It's not nothing, or don't chart anything or anything like that. You need to write down empty. You couldn't feel it. So keep that in mind. If we say during your passive range of motion testing that one of the actions you were doing, while you're doing it, will tell you that they couldn't complete that because it's painful, then you need to chart as it is empty because of pain. Okay? If we say they can't complete it because it's too tight, it's not painful because it's too tight, then you need to chart as abnormal end feel, left abduction, whatever motion, I'm just giving an example, tissue stretch. It's nothing to do with pain. You actually were able to feel the tightness. It was just too tight that it couldn't complete full range of motion. That means that it's abnormal end feel, because normal end feel would have to be really reaching to the max of that particular range. So in this case you couldn't, so it would be abnormal end feel, left abduction, because that's the example, left abduction to shoulder, left abduction, and tissue stretch. Now this is where it gets a little bit confusing sometimes. Tissue stretch can be seen as a normal end feel and an abnormal end feel, just like a tight muscle. So the idea is that what we are looking for is it's tight, so we couldn't reach the full range of motion. That's why it's abnormal end feel, even though it's technically same end feel that you would feel. So the range is important here. That's why we're gonna say they couldn't complete the full range of motion, and the reason is either it's painful, then you need to write empty here, or it's just too tight that they can't do it, then you're writing tissue stretch here. We're gonna keep it very simple. There are other abnormal end feels. We're not gonna go through any of those. You can find out later on in the future throughout your program how many different ones. But for now, we're gonna keep it during the OP with painful needs to write down empty, or tight you need to write down tissue stretch. Okay, that's the only time that you're using abnormal end feel, only when it's passive range of motion. I can't stress this enough, because this completely gets lost for some reason during the OPs, or people don't understand. So I'm hoping that this video will clarify that once and for all. Or if you're doing a resistant range of motion, again explaining the procedure to the client and get consent, patient is positioned properly. That is where you lose most of your marks, because I want you to keep the joint in the open pack position the whole time. I will stress this enough, hopefully, in the lectures and during the tutorial as well, that this needs to be in the open pack position the whole time. So this is where people lose points, so keep this in mind. Unaffected side first, bilateral, logical progression, all movements tested, same thing, just like there is passive range of motion. Most painful last, just like before. Here you have to count from 5 to 1. You might actually lose marks here if you're too fast, too slow, or basically you're counting from 1 to 5. So keep that in mind, please. It has to be from 5 to 1, and hopefully this is pretty straightforward. And check pain just like before, and record resistant range of motion correctly, which already has its own place. So it's very straightforward. Write down the joint, again in this case let's say shoulder, and then you can write down whichever order you like. There's no particular mandatory order. You could technically write down everything the way you want and leave the most painful last. So let's say abduction was the most painful. You could say flexion, extension, external rotation, internal rotation, adduction, and abduction. And then you already have left and right here, so you need to write, grade them according to the grading for the resistant range of motion, starting from 5 finishing at 0, and then again here starting at 5 and finishing at 0. So if it's just record, like basically refer to your range of motion, resistant range of motion marking sheet to record it whatever you feel. And then also on the side here you need to write down pain, whether no pain or yes pain. So one more time, please refer to your how to chart examples and many examples that I put on the SharePoint and in the video that you're gonna watch for how to chart video. So please refer to that. So you should know what to do by now on that, okay? So refer that for no pain, yes pain, no pain, yes pain. Now the common mistake during the resistance range of motion testing, we might actually tell you that hey, it was actually painful on that action and they weren't able to completely do it. Now the second we say they weren't able to completely do it or it was painful, right away you immediately write down 3. Now the problem with that, when you look at the grading system, 3 means they could do it on gravity, like they could just lift their limb up. But that's not what we're saying. It doesn't automatically make it 3 just because it's painful. What we're looking for is like, it's not 5, okay? It's not 5 plus. It's not like maximal pressure was pushed and the client was able to handle that. So we're looking for 4. We're looking for 3 plus. We're looking for 4 minus, whatever, like somewhere in there. If you only put 3, that means that it's unrealistic because they were able to handle for a while. They were able to handle for a degree. So it's not accurate. So that's why you end up losing marks if you just put 3 there. Okay. That's why record resistance range of motion correctly means that whatever you're feeling needs to be put down there. So if we say painful, obviously put pain, but don't automatically make it 5, 5, 5, 5, 5, 3, because that's not what happens. So basically what we're looking for is, as much as realism is concerned, 4 plus 4 plus 5, 4 plus whatever was happening in the exam, and then the last one would be maybe 4 still painful, but they were able to handle to a moderate resistance or a minimal resistance. At least it should be 3 plus. So keep that in mind, please. And then that's it. That's out of 20. Okay, so 12 points for the resistance range of motion or passive range of motion, and then 8 points for the functional. That's why 8 plus 12 is 20. Okay, so that's what we are basically looking for. And then 20 plus 30, that's how we get to the 50 out of 50 marks. And that's it. So if you have any other questions after you're watching this video, send me an email or ask me in class during the tutorial. I will be uploading this pretty quickly. And then if you're watching this in a term or two anyway, so that's not the problem. I'm talking about to the current term. So you should be able to watch this and be able to come up with questions if you still have any, and I can clarify them in class. Or basically just send me an email and I will answer as much as possible. There is also like this one on the SharePoint, and I also put a midterm OP direction on the SharePoint as well. There's describing much quicker, obviously, as in one page on exam for this. So please keep that in mind. You can read through this and get even more information. And basically that's it. Hopefully it will clarify as much as possible. Again, we're looking for patient and date and therapist names and functional assessments. General observation here is like no orthotics, etc. Palpation here. Small guy for the primary of concern. You have your joint for AROM, PROM, and ROM. For ROM is here, excuse me. So AROM and PROM and ROM. Your abnormal end field is here, and you don't need to do anything else here. And for alignments, again, your patient name and your date. You need to write everything down here. And these are some of the examples that you could use, but we still again want to see therapist and class and term right here. Okay, term is again your term 1, class is whatever your class is. It's not clinical assessment. Don't write down clinical assessment, whatever your class is. Okay.